I'd like to go ahead and welcome everybody to this afternoon session. I'm Chad Gonzalez. I'm a member of the Ogden Surgical Medical Society Board as a CME director, and I'm thankful for this chance to moderate this session. I'd like to remind everybody of other sessions going on adjacent to this room and in skill sessions in other rooms of the conference center today. I'd like to introduce our first speaker here in the afternoon, Dr. Matthew Peterson. He will be giving an update on infertility. Dr. Peterson is a reproductive endocrinologist in the University of Utah Department of Obstetrics and Gynecology. He received his undergraduate degree from Brigham Young University and his medical degree from the University of Utah, and did training in obstetrics and gynecology at the Maricopa Medical Center in Phoenix, Arizona. And I look forward to hearing from him. And help me welcome Dr. Peterson to the stand today, and we'll hear from him.
Well, I appreciated the last lecture, and I just wanted you to know that I've practiced at the three major institutions that have medical records, the University of Utah, Intermountain Medical Centers, and at the VA. And I describe my days as follows. On one day, I'm a 3,500 click physician. On another day, I'm a 7,000 click physician. And on the final day, I spend most of my time doing, what do they call these things where you're becoming a better doctor and you're having all your trainings. So at the VA, I spend almost half the day keeping up the trainings. Today, they've asked me to talk about an update on infertility. And so what I've done is taken, over the last couple of years, a potpourri of all the things that are most critical issues that are facing us. They're ethical and financial conundrums that we've gotten ourselves into. And so as I go along, I'm going to kind of point out why we're where we are. The first topic that I'm going to talk about is in vitro fertilization, which we've recognized since 1978 as a wonderful procedure. But there's some cautionary tales that have to do with finances and how medical interventions begin and how they affect how we practice and how they're instituted, and how appropriate research and validation of what we do is something that doesn't happen in industries that are allowed to operate on their own. I'm going to talk about PCOS. This is from a book chapter that we had to write, and the editor of this book asked us to figure out the cheapest, most effective way to rule out all the major differential diagnoses of PCOS. So in 5 or 7 lab tests, you can get to where you need to go and know what's going on. I'm going to talk with you about infertility treatment risks, thyroid guidelines that are now present. As you're aware, a couple of years ago, they told us if someone's wanting to get pregnant, their TSH needs to be less than 2.5. That's now wrong, and so I'll kind of update you on that. Because we're trying to take care of people, the two last things I want to talk to you about is air pollution and nutraceuticals. I'm biased towards science and intervention. I don't have any financial or scientific bias for this talk, but I realize that it can happen. I have royalties from product development for clinical innovations. I have stock and patent rights with TheraTarget. This chapter that I'm telling you about, that I have some slides from, Barracks, Novak Gynecology. If you want the slides for this and you ask me to give you the slides, I'll give you the slides, but I might give you something else. I'm the PI for 2 large studies from the National Institutes of Health. This first topic I want to talk about, I want to review the biology of the early embryo and why this is so important, and why this has gotten to be a financial issue, and why some things have developed that have not been scientifically validated that you should be aware of as you talk to your patients. I'm going to review our field's forays into genetic evaluation with early embryonic tissues, which we used to call pre-implantation genetic screening, and it's now called pre-implantation genetic testing for aneuploidy, which has created some issues that I'll point out that each of you need to be aware of as you talk with your patients about fertility treatments. I'm going to assess the possibility of gene editing based on a seasoned and candid assessment of our specialty and our own history into genetic analysis. As you're aware, IVF has actually been in my lifetime. So it started after I was born. The first IVF was done in 1959, and then the first baby was born in 1978 in England. Probably the big issues that have come to play in this area are our ability to do intracytoplasmic sperm injection in 1992. And that's where we could then fertilize with sperm and inject it into the embryo. Another important area that changed IVF was our ability to vitrify embryos. And so we can now freeze embryos, save them. We've had embryos frozen for over 17 years and been able to use them. And so these can be saved for a long period of time without much damage. And our rate of coming out of a thaw from vitrification is 97%. I'm going to talk about these two issues and how they relate to some things that you've read about in the news and some things that you need to be aware of. The first thing I want to point out is that in my area of medicine, the NIH had a bill or an amendment that's called the Dickey-Wicker Amendment. It's a strange name. That amendment says that there can be no embryo testing. So in essence, the NIH has decided there will be no funded research on embryos done by the government. And there are a lot of reasons for that, but when those kinds of things happen, then research goes off in another direction, which is often driven by financial motivations. So you need to be aware that a lot of what has happened has been driven by private industry, all of which has been helpful. When I started doing IVF, we were happy with an IVF pregnancy rate of about 5%. We now run 60 to 66% for regular patients. If somebody uses donated eggs, it's 60 to 80%. So it has changed a lot over the years, but a lot of the things that we have done have been by unvalidated method development. So things that industry have brought in that have not been fully tested. As you're aware, people have interest in what we're doing because we're dealing with tissues that have great potential. So from day 1 to 3 of an embryo, if you were to take a cell off this is totipotent. It can become almost anything. So people who are doing regenerative medicine or things like that have great interest in these tissues. From about day 3 on, day 4 on, they become pluripotent and can become multiple different cell lines, and then as organs begin to form, they become multipotent. This just shows where embryos are in development. They fertilize out here at the end of the fallopian tube, and then during this stage, they're pluripotent, or totipotent, and then as they become morulas and move into blastocyst stage, they become pluripotent. Now I'm just going to show a little section of this. Can you turn that video on? If you click that, the video should come on. Okay. So this is something that you don't get to see very often, but this is the embryo development. And so this is a 6 to 8 cell stage, and this would be a day 3 transfer. So 15, 20 years ago, we transferred on day 3. Not exactly the right time for that embryo to arrive in the uterus, but this is when we would transfer embryos in the past. And these represent pluripotent cells. And now you see it moving into a morula stage, which does not have a blastocyst, but it's beginning to form the intercell mass, which is the baby. And then as it continues to develop into a day 5 embryo, it becomes a blastocyst. So you can see a cystic structure forming, and then right in this area is the inner cell mass. This is the baby. The rest of this is placenta. I'm going to skip this one. Now, when we test an embryo, if we have a patient that has a genetic disorder that we need to evaluate, like cystic fibrosis, the most common reason we do that here, then what we're going to want to do is biopsy some of these cells off and see if this embryo carries cystic fibrosis or some other genetic disorder. And so this represents a biopsy. And I'm showing you this slide because you need to be aware that this cell mass, and we're biopsying the trophectoderm, and so there are about 300 cells in the trophectoderm. This is actually not the baby. This is placental material that we're testing. And we're going to pull off 6 or 8 cells. 6 or 8 cells, we might get that much DNA. We may get less than that. And so I just want you to keep this in the back of your mind when we're talking about doing a biopsy and whether this actually represents what the baby is. We're testing 6 to 8 cells of 300 cells, so about 2%. So that should give you an idea right off that what we're testing may not be totally appropriate. Additionally, placental tissue is highly mosaic. So sometimes this tissue is just like all of us. We make bad cells. We kill bad cells in our body. So it's possible that these cells that I'm not biopsying, but the cells that are being biopsied off at this time do not actually completely represent what that embryo is. It would be nice if that was the case, but in reality, that is not the way it is. Now, I'm just showing you here a couple of slides just to show you what can be done in terms of manipulation. So we all like procedures. These are procedures. These are things that we do. So people want to promote these kinds of activities. This is where we can go in and inject DNA into this cell, okay? So they're actually injecting the pronucleus with DNA, and so you can put things right inside the nucleus. These are embryonic stem cells that actually also can be injected into an embryo. You could inject mitochondria for mitochondrial diseases. You could do a lot of things to improve the health of that particular embryo or to change the trajectory of a family's history with regards to a certain type of problem. So there's great potential here for us to do lots of very interesting things. Now, the concerns are, what are we going to edit? What kinds of things would we edit? All of us have heard about CRISPR-Cas9, and part of what I want to talk about is some of our forays into this and how it has led to some problems that we see internationally. So, this human genome is all of our genetic material, and the process of attempting to make precise additions, deletions, or alterations to a human genome is something that people would like to be able to do. Somatic gene editing would mean that these are somatic cells beyond the germline, where we're going to try to change some of those cells, whereas germline editing would be these things that I'm talking about where we're doing things in the 3 to 5 day embryo stage. And if you do it in this stage, then what you change is changed forever and you can't go back. It just keeps coming out every generation after that. CRISPR-Cas9 is a new technique of gene editing that's easier and apparently more efficient. Now, if you'll turn the audio on, I just want to show this piece for a second.
Scientists have long imagined being able to make specific changes to the genetic code of a cell or organism. A revolutionary genome editing technology makes this possible using an RNA-guided protein called Cas9. Cas9 searches through the cell's vast genetic material until it finds a sequence of DNA that matches the sequence of its programmable guide RNA. The guide RNA enables Cas9 to open the DNA helix, then to position 2 molecular blades to cut each strand of the DNA double helix. Repair enzymes seal the gap in the broken DNA, sometimes by inserting new genetic information supplied by the cell or the experimenter. In this way, disease-causing mutations can be corrected by changing the underlying genetic code. Scientists are now using this Cas9 technology for research applications in human health, agriculture, and bioenergy.
So that is the hope. And what I'm proposing today, that we need to be very cautious because of our past experience. Hubris is a quality of extreme foolish pride or a dangerous overconfidence. In its ancient Greek origins, it describes behavior that defies norms of behavior or challenges the gods, which in turn bring about the downfall or nemesis of the perpetrator of hubris. So this is Icarus. He got too close to the sun, the wax on his wings melted, and he drowned. Obviously, his dad, who taught him how to fly, said, you know, don't get too close to the water because you'll sink, you'll crash into the water. Don't get too close to the sun. And I think we need to have the same qualities about what we're doing because of our own cautionary tale, which I'm going to go through right now. So in the early 2000 to 2008, we heard the story that, you know, we can take these cells and we can biopsy them like I showed you, and we can tell you what's going on. And so we initially started doing cleavage embryo biopsy up until 2008 and determining whether we thought that baby was normal or abnormal and transferring based on that. What it turned out was that cleaving embryos are just like all of us. They're rapidly changing and they're mosaic not infrequently. And so it turns out that finally science, good science, caught up with capitalistic-driven innovation and said, wow, what are you doing? Because you can't really tell what's going on. And so for about an 8-year period of time, we did this, and we were actually calling things abnormal that were not abnormal, were likely not abnormal at all. And it took international organizations to stop this behavior. So you would have thought PGS number 2, which would be a biopsy later on in the blastocyst stage, would have learned their lesson and said, you know, maybe we ought to slow down and do some more animal experiments before we move into humans. But that was not the case. So PGS2, what we're doing presently, is biopsying the trophectoderm. And I guess the questions that I would ask us all, does a 6-cell trophectoderm biopsy reflect all of these 300 cells? Does the trophectoderm chromosomally reflect the inner cell mass? And how much does the inner cell mass self-correct downstream from the blastocyst stage? All questions we had no idea. But an industry has developed based on this, which is now changed from pre-implantation genetic screening to what has been changed to pre-implantation genetic testing aneuploidy. It's estimated that this industry is somewhere between $100 million and $550 million industry per year. This is just some micrographs that show blastocyst biopsy. So this represents the trophectoderm. This is where it's been cut. This is the inner cell mass on the inside. So this is just the cautionary tale that I'm giving you. We learned from 6 to 8 cell embryos that PGS in the 6 to 8 cell embryo stage, as practiced, was ineffective. Yet, soon thereafter, we started doing trophectoderm. The proposed deliverable was improved IVF outcomes and reduced miscarriage rates. As of 18 and 19, these are the most recent statements from our professional organizations. There's insufficient evidence to recommend routine use of pre-implantation genetic screening, now called pre-implantation genetic testing for aneuploidy. Multiple platforms are used, including an array of comparative genomic hybridization and high-resolution next-generation sequencing, which both lack appropriate validation prior to their clinical utilization. Prediction of mosaicism is marred by technical limitations. So in my field, we've done this twice. There's big controversy going on right now. There's a gigantic industry, and there's a lot of people selling it. An IVF clinic makes money by doing this. The people who sell the platforms make money by doing this. Whether it's actually appropriate or not is still questionable. Now, to give you a little more perspective of what has happened, there are some scientists. I'm just going to move ahead one slide. This lady, Helen Bolton, in a Nature Communications in 2016, did embryo work. She was 44. She wanted to have a baby. Her doctor told her, if you do pre-implantation genetic testing for aneuploidy, we can tell you which ones are abnormal, which ones are not. She did it. She didn't get pregnant with her, quote, normal embryos, but she had some left over. And in those leftover ones, they were called aneuploid, meaning they had abnormal chromosome numbers for certain ones of the chromosomes. She did research, and in her research, what she did was take reversing treated embryos, and she could marble the embryo. So she can make a 3-to-1 marbling, a 1-to-1 marbling, and then compare them to her controls. And even in those that were 2/3 marbled abnormal, 11 of 25 viable normal mice were born. In those that were only 1/3, 100% of them were normal. So she recognized that, hey, this is not quite right. What they're telling me, this embryo that I have may be totally normal, and she forced her doctor to transfer it. She transferred it. She had a healthy, normal baby. Okay? So I'm going to go back here. Since that time, in this year, we've created 111,000 embryos have been screened using PGS, using an array comparative genomic hybridization. 40% of those are rated as normal or aneuploid. Transferred embryos are routinely normal. However, just like Dr. Bolton, people are beginning to say, I don't know, maybe this one's okay. I'm going to transfer it. These represent some papers. There was in this year another paper of 100 babies transferred, which are completely normal, that were labeled aneuploid. So the bottom line that I'm trying to get to here is we need to be careful about what we say and what we do and how we have tested it. And I would tell you, in the industry, in here, having done it, I don't recommend pre-implantation genetic testing for aneuploidy. It comes free with people who do pre-implantation genetic diagnosis for people who have cystic fibrosis. But to screen embryos and say they're normal or abnormal, the studies have not been validated. It's prior to human use. You might get some information from it, but I would not tell you that that's an appropriate use of a technology, because I don't know what the answer means. Now, when people want to transfer those embryos, what we tell them is probably the pregnancy rates are a little bit lower, and it looks like the pregnancy rates are about 30%. We in our program have never had an abnormal embryo in someone who got pregnant with an aneuploid embryo. So if it's kind of like an all or none thing. If you get pregnant, it's probably going to be okay. We still recommend that you have testing, but it's not something that we would routinely say is a great idea. You will find many programs who will tell you this is the only way to have a healthy baby. It reduces time to pregnancy, and we could get into an argument about that. Now, with regards to correcting CRISPR-Cas9, so I'm laying the story of the caution, and now I'm going to jump to CRISPR-Cas9. People want to fix babies. We want to fix them. And this is a study that was done appropriately, in an appropriate way, using embryos that were going to be discarded, and they corrected a pathogenic gene mutation that causes hypertrophic cardiomyopathy. And we're very successful in that process. There are a lot of comments and criticisms about this regarding non-targeted mutations, so you can't say exactly where CRISPR-Cas9 is going to go and what it's going to insert back in. Indels or deletions, suggestion that co-injection of sperm and CRISPR-Cas9 components reduces mosaicism, so there may be ways to do it that are safer than others. Sampling size errors, and using embryo development as an indicator of well-being. So just be aware that this is an area of active research that ought to be done in an appropriate way. Now, are we good at doing it the appropriate way? this is a thing that was put out by the ASRM. So they had a journal club where we can all hook in and listen. So they are like you are today. They're hearing about CRISPR-Cas9 for the first time. They, because they're in our industry, knew a little bit about IVF. They knew about PGS. They knew about our ability to test embryos. So they felt like, they had a little knowledge of it, and we probably would answer the same way. Should gene editing be allowed? So I hope after this talk that you would never say yes. But that's what we said. That's what was said in this little conference. If it was available after, a conference like this, if it was available, would you offer it? Yes. What percentage of my patients would take it? A high percentage. Should we do research in embryos? A large percentage felt that should happen. And should gene editing be allowed? So about more than half of people were saying this is a good thing. I really don't know a lot about it. I would caution you, as I caution myself now, things sound good, it sounds like a bright future, but boy, we ought to be a lot more careful about the kind of testing that we do. The National Academy of Science has recommended these guidelines if gene editing is ever done. No alternatives to that problem. There is no other way to get around it. Restricted to serious diseases or conditions, and only edit genes that are convincingly associated with a disease or condition, converting such genes to versions prevalent in the population that have no adverse effects. So knowing about what the gene pool is. This is 10 years worth of work, just this condition right here. Availability of credible preclinical or clinical data, this is another 10 years. So we're talking about 10 to 20 years of appropriate validation of what we're doing before we do it. We should have rigorous oversight, long-term multi-generational follow-up, meaning 3 generations afterwards. So now we're talking about 40 years. Maximum transparency consistent with patient privacy, continual assessment of health and safety with broad public input, and reliable oversight to stop unapproved use. This is Dr. He in China. He trained at postdoctorate work. He trained in 2 prestigious universities in the United States, had ongoing conversations with his mentors. He decided he was going to do CRISPR-Cas9 on children that were at risk of getting HIV. So the father had HIV, the children's risk of getting HIV would be higher, so he decided he wanted to insert a gene that essentially made them very resistant to HIV. Hid it from his university, hid it from the patients, hid it from the IVF doctors, did it, transferred 1 embryo that he had edited and 1 embryo that he hadn't edited and had twin babies, and is now likely going to go to jail in China. And there's been great public outcry about what has happened. So you just need to be aware that we who are in these fields need to make sure that we're doing all we can to make sure rogue people don't do things that are inappropriate. There were multiple conversations between him and his mentors that gave the impression that he was going to do this, and something ought to have been done before he did it. The first time I gave this talk, it was at a religious and science discussion, and these religious leaders and ethical leaders give us some things that we ought to think about. And this one I really like. Real knowledge is to know the extent of our ignorance. And I would just tell you, we're pretty darn ignorant. And we've jumped far ahead, and it has been driven by financial mechanisms. So again, that industry today is worth somewhere between $100 and $550 million. And there's not a meeting that I don't go to where this is not driven, pushed at me. Okay, we're going to move on to PCOS. And there are some big differentials with regards to PCOS that you don't want to miss. So Cushing's syndrome happens. It's not very common, but it does happen. People who have adrenocortical tumors with high testosterone levels happen, and there are ways to evaluate that effectively. As you remember, polycystic ovary syndrome is a complex disorder with some multi-gene effects, so it's probably polygeneic. It is associated with multiple insulin activity gene abnormalities. There are probably also some pituitary effects. High insulin levels result in increased androgens, which makes it hard for ovaries to work. We also now know that insulin and some of these other genetic activities also affect the fat of women who have PCOS, and we've begun actually looking at highly sensitive CRPs in women who have PCOS, and we find that about 15% of them have mild elevations of CRP. So there are things that are probably going on here that we haven't even recognized to the same degree. This is in that book that I was telling you, and you might get this chapter if you ask for it, but there's a fairly simple way for you not to miss serious disorders with regards to PCOS. And so you can have the patient self-evaluate herself for hair growth, and that's the most effective way for them to do that, because when you look at a patient, they actually come gussied up and all cleaned up and no hair growth on them. And so you want the woman to self-rate herself with regards to the Ferriman-Gallwey scoring system. Most women who have some type of abnormality, which would represent Cushing's syndrome or an ovarian or adrenocortical androgen-secreting tumor, most of these women are going to have Ferriman-Gallwey scores usually above 20. Women who have garden variety PCOS are going to have values that are less than 8. And remember the Ferriman-Gallwey score, it goes 1 through 4, but there's also a 0, which isn't on there. So if they don't have any hair growth symptoms, they're not going to put a number for that. It is worthwhile sometimes to get non-classical adrenal hyperplasia or adult onset adrenal hyperplasia. Most of the congenital adrenal hyperplasias are diagnosed by pediatricians before they ever come to see you. So this is something that can drive androgens. When women who have high testosterone levels, we go down this pathway looking for tumors. The majority of patients that you're going to deal with are going to be up in this quadrant where you can use oral contraceptive agents or things to help them ovulate. But if they have certain symptoms that would suggest they might have Cushing's syndrome or might be more hirsute than you would expect, then you need to do 2 other labs. So you do the Ferriman-Gallwey score, but then you would get a 17-hydroxyprogesterone, and then if you don't take anything else from this meeting today, if you ever order a testosterone, which will likely not be very often, maybe 10% of the time, please only get a bioavailable testosterone, which will measure their free testosterone, their total testosterone. It measures albumin and sex hormone binding globulin, which change in people, and it changes how that testosterone actually works. So if you ever draw a testosterone level, get the bioavailable testosterone level. Women who come in over 200 and a free testosterone level greater than 6.85, they may well fall into this, and you can go straight down the pathway for adrenocortical tumor. A lot of the women who have acanthosis nigricans, so Pacific Islander people who have high levels of insulin genetically, are going to fall into this category, and that's when you might work them up for hyperthecosis or Hair-Ann syndrome, which requires a little more treatment, and I'll show you that in just a second. So what we do is give patients this little graph, and remember there's a 0 that is just not on here. And then they give themselves a number for these 9 body areas, and if they're 8 or less, you can treat them like a regular PCOS patient. About 80 or 90% of your patients will be that way. If they come in higher this on their own self-ranking, then you have to think about, is there anything else going on with this lady that I might need to look at and want to evaluate? And the 4 things that you should think about are these clinical findings. If a patient comes in evaluation for Cushing's syndrome. So all you have to do is have them do a deep knee squat. If they can't get back up, they likely have it, unless they have some other limb girdle disorder. So proximal muscle weakness is a really classic sign. This seems like not a big deal, but it is a big deal. So in patients, in large studies that look at Cushing's syndrome, a dorsoclavicular fat pad, so this is before and this is after. So if you see this, that should make you mildly concerned that this person may have elevated cortisol levels. Stria, and they can be very thin and even less than this for patients who have Cushing's syndrome, and a moon facies, so kind of it gets rounder and rounder, and it's particularly helpful if you look at an older picture of the patients. So anybody that comes in with one of these things, the screen for Cushing's syndrome is a 24-hour urinary cortisol. You don't need to do all these other things, and this is the most sensitive screen. So drawing a blood test in the morning is nice, but if you want to do one test and say, yeah, you got something, or no, you don't, it's the 24-hour urinary cortisol. So you would get that. If that's positive, then you would get one more test, a late-night salivary cortisol or an overnight dexamethasone. So if you don't want to do a bunch of drug administration, it's these two tests. And if you have those two tests, then you send them on to the endocrinologist. Cushing's disease, or pituitary-driven, is the most common, or an ectopic secreting ACTH tumor. So you can diagnose Cushing's syndrome relatively quickly using this algorithm. Now, we don't in this population have lots of ethnic diversity, but we do have all of these ethnic varieties, and these people are at slightly higher incidence of adult onset adrenal hyperplasia. The reason why it might be useful to diagnose this is not necessarily for them, but for their kids, because they may carry one of the recessive traits that if they marry the right person, their child could end up with congenital adrenal hyperplasia. So it's a worthwhile diagnosis to make for future generations. This is that test that we said you'd get if their ferritin Galloway was over 9. It's the 17-hydroxyprogesterone. If it's over 300 nanograms per deciliter, they have a simple ACTH stimulation test. If it comes out between 1,000 and 10,000, then they have adult onset adrenal hyperplasia. Those patients often don't need anything other than what you would normally do for a PCOS patient, but you may have identified somebody who you should do a genetic workup on, who, when they start having children, their spouse would be tested for the possibility that they could have a child that has full-blown congenital adrenal hyperplasia, which could result in ambiguous genitalia. Now, the majority of the patients that we're going to deal with fall in this category here, and that would be a 17-hydroxyprogesterone that's normal, and then a testosterone level that's either totally normal and a 17-hydroxyprogesterone level that's normal. So this would be a little more than garden variety PCOS. And those patients need weight reduction. They can use oral contraceptive agents to increase their sex hormone binding globulin, because remember, androgens reduce estrogen's production of sex hormone binding globulin from the liver, make them have more elevated free testosterone, so all of those symptoms become more complex. So birth control pills is really a helpful thing for women who have PCOS that are not trying to get pregnant. A lot of these patients have insulin resistance, and so metformin is something that we use a lot to help these patients in this category. And then if you want to block androgens at the skin level, you use spironolactone. You have to use 150 milligrams per day, 50 TID, to block the dihydrotestosterone receptor and reduce their hair growth. So this is the way we would manage those patients. Additionally, patients who are falling into this a little more severe PCOS than the garden variety PCOS, you want to evaluate them for metabolic syndrome, because these are the things that are going to end up causing them long-term health disorders. And so these people that fall into this category probably should be worked up for this. You will probably find 1 or 2 times in your career somebody that has an androgen-secreting ovarian or adrenocortical tumor. But you can pick them up because their testosterone level is greater than 200 nanograms per deciliter. Their free testosterone level is almost 7 nanograms per deciliter. These 3 tests will put them in the category of one of these tumors, and then you talk to the radiologist about what is the most effective screening method for these patients who might have an adrenocortical tumor. And again, metabolic syndrome is a good thing for us to know about. Now, I'm just showing you this slide because our society has now created 4 types of PCOS. So the criteria that lead to the diagnosis of PCO has now been broken into 4. 3 of them show hyperandrogenemia. 1 of them just shows oligoovulation and a PCO morphology on ultrasound. But these other 4 are different combinations of that. Over the next 10 or 15 years, I suspect that we will have these 4 types, and we will know this type goes with this type goes with this, all of them go with all of them. And so you'll be able to classify people with regard to their PCOS and what kind of downstream problems they're going to have. Probably the biggest issue is weight, and so there'll also be criteria that help us know would those patients really need to be moved towards bariatric surgery or some other more effective way to help them keep things under control. Additionally, as personalized medicine comes on board, all of our criteria for treatment, so those of you that are doing primary care and making sure that they're on statins when they're supposed to be, the guidelines for the target values are different for different types of PCOS. So general PCOS has these guidelines for LDL and non-HDL targets. PCOS with metabolic syndrome is a different ball game. If they have type 2 diabetes on top of that, it's another ball game. So much more aggressive therapy for those who have more severe brands of PCOS. These are various treatment options, and I would just tell you that because 80 to 90% of people kind of fall into the same category, if I have someone that comes in with a BMI over 30 and there's any evidence of insulin resistance, I start people on metformin. If they take the long-acting variety, I have them take 1 500 milligram tablet at night for a week with dinner, and then the next week I have them take 1 in the morning with breakfast, 1 at night for a week. And then the third week, I have them go to 2 in the morning and 1 at night. So they're on 1,500 milligrams of metformin XR, and that will help them lose 5 to 7 pounds of their body weight. And because a lot of the patients I see want to get pregnant, it also helps them to respond to ovulation induction drugs better. But they need to be on that kind of dosage to have it be effective. For those that are not trying to get pregnant, if they're concerning, I've gotten a testosterone and a sex hormone binding globulin level with the bioavailable testosterone. And you'll be surprised how many women run around with really low sex hormone binding globulin, which means that all the testosterone they make is just being active. And so you want to do something that will increase their sex hormone binding globulin, and you can do that by adding low-dose birth control pills, and some people that don't really need birth control pills, we'll just give them low-dose estrogen to increase their sex hormone binding globulin and reduce their hirsutism and other side effects. And then obviously a lot of patients I see want to get pregnant, so we give them ovulation induction medications. I wanted to jump next to things that you should tell patients about getting infertility care, whether that's ovulation induction or in vitro fertilization. There's been stories about this over the years, and this is an excellent study out of England, followed 250,000 people almost, and the worry is ovarian cancer, okay? And so people who are infertile and treated with infertility medications appear to have an increased risk of ovarian cancer. And when you go to the breakdown of this, whether it's invasive cancer or borderline tumors, what you get from this slide and the discussion that goes along with this paper is people who have endometriosis, particularly endometriomas, are ones who have these elevated risks of ovarian tumor. Additionally, people who are infertile, meaning they've never had a child, are also at risk. So some people feel that infertility is just a manifestation of an increased risk of ovarian cancer. So people that have endometriosis and are infertile and receive treatment probably need to be monitored at least for a slightly higher risk of ovarian cancer. Now, a few years ago, we in OBGYN were told that we needed to, if someone was trying to get pregnant, we needed to have their TSHs less than 2.5, good for the baby's brain, reduce the risk of miscarriage, all of these things. So we all started screening for TSHs in women who were thinking about getting pregnant or were pregnant. And remember, the physiology of this is that 1 millionth of HCG has 1.3 thousandths of TSH activity, so it's a weak stimulant, resulting in an increased free T3 and T4 that's incompletely counterbalanced by the estrogen-induced increase in thyroid-binding globulin. This causes your TSH to fall transiently in the first trimester such that the normal, the actual real normal, is lower than it would be for a woman who is not pregnant. And we were advised 2.5 was the appropriate value. And that has now changed because the American Thyroid Association has been monitoring what we do and how we've driven this market along. And what we found is that we're over-treating. So now they recommend we use a population-based, trimester-specific TSH level in the first trimester, which means it's not 2.5. So ARUP is the only laboratory in the state that I know of that has done this and taken all the pregnant ladies, and they have created a new range, and the new range is 0.03 to 3.4. So they're normal up to 3.4, and then above that, then you would say this patient might have subclinical hypothyroidism. Without population-based pregnancy data, reduce the lower and upper limit of TSH by 0.4 and 0.5 respectively. So that's what the society is saying, just drop the numbers down. For Intermountain, which has not done that yet, so for patients that are in the Intermountain system, if you adjust according to their recommendation, then the new normal would be 0.12 to 5.75, which is higher than large studies done in other big populations. I've talked with Sterling Bennett, and they're going to do the study on the Intermountain patients, and so sometime I suspect within the next year, Intermountain will create pregnancy-specific TSH values by trimester. In the absence of reference ranges, TSH, the standard you could use is 0.1 to 4 if you're somewhere that doesn't use those lab systems. And your total T3 and T4 are about 1.5 times higher than that in the non-pregnant woman. So a testing strategy would be, we get a TSH, it's out of range. What I always do is retest. And 50% of the time, the retest is totally normal. So always retest. So you retest, and at the same time, because I do infertility work and I recognize that women who have thyroid peroxidase antibodies that are elevated are at an increased risk of having miscarriages, I kind of want to know that. And so I will get an antithyroglobulin and an antimicrosomal or a TPO antibody, and then I determine if they have Hashimoto's thyroiditis or Graves' disease based on this TSH. Women with repeat normal TSH but have positive thyroid peroxidase and undergo IVF are at a twofold relative risk of miscarriage, so it's significantly higher. And it appears that treatment of these euthyroid women with positive TPO antibodies will reduce their miscarriage rate. If you're euthyroid, TPO positive, but not doing IVF, but you have a history of miscarriage, the American Thyroid Association says go ahead and treat them with 50. If there's no history of miscarriage, they don't recommend treating. So this is all new, and you'll see this come out with ACOG and the Endocrine Society later on. It's important for patients that have subclinical hypothyroidism to recognize there are two patterns of postpartum thyroid dysfunction. You can have postpartum thyroiditis, which is characterized by transient hyperthyroidism or transient hyperthyroidism, followed by transient permanent hypothyroidism. Or you can have a postpartum exacerbation of your Hashimoto's thyroiditis, which is part and parcel of more autoimmune destruction. It causes a slight elevation of thyroid hormones early, and then they drop down. So you need to keep in mind that these patients are also at risk with that, which also goes along with postpartum depression. Now, what can we do to help our patients be more healthy? This is where I get political, okay? So these are environmental risks. This is Salt Lake City. This is 3rd South. This is 4th South. This is an inversion. This represents PM 2.5s, and if you don't know, you can go to the Utah Physicians for a Healthy Environment. They have all kinds of data. But PM 2.5s are associated in many studies with birth defects, all kinds of cardiorespiratory disease, diminished fecundability, loss of reproductive capacity, lung cancer, reduced sperm parameters, menstrual disorders, and stillbirth. It is the 6th leading cause of premature death. If you want to do anything, you speak up like our last speaker was talking about in a collective voice and say, wow, we've got to do something about this. Now, I will tell you that we have done better over the last 40 years. So this is PM 2.5 air quality for about 20 years in the United States. There's been a 20% decrease in the Southwest. Nationally, the decrease was 41%. So people being after this has made a difference. PM 2.5s are a combination of nitrates, sulfates, dust, and stuff that comes out of our cars and heavy equipment. And they get together, and these can go into the deepest, innermost recesses of your lung, and it's like eating bacon every day, okay, which is not good for you. And so you increase your risk of lung cancer dramatically and all these other cardiorespiratory diseases. The people who treat lung cancer here say this may be one of the primary causes of lung cancer in non-smokers who live in Utah other than radon. So if you don't have radon in your home and you get lung cancer, then this is likely the source. This shows a PM 2.5 map in Salt Lake County. This represents about 16 weeks. So the red and the blue are where we're not making it, okay? So we have a problem in those weeks of the year, and obviously it's mostly in the winter where we have inversions. This is just another way of looking at it. All the red things are wrong. And you who live in Ogden or other places might think, well, this doesn't affect me. But it does, and these things travel 100 miles, okay? So if we create them in Salt Lake, they're going to get you wherever they go. This is national data, and these are called the non-attainment years. And I'm just showing you, you can't really read this, but this is Salt Lake County for PM 2.5s, and you know, all these years are years where we're not making it. And these represent Salt Lake County, Davis County, Tooele County. And then we go to Weber County. And so there are issues here. And when we talk about PM 2.5s, we also need to talk about PM 10s because they include the PM 2.5s. PM 2.5s, other than burning wood and coal, these are the things that are causing it. So not only does diesel fuel cause it, but our road and brake and tire wear. So all these cars that we drive around are causing this issue. This is the biggest environmental threat that we could have, and this is called the Salt Lake City Inland Port, which your legislators have wisely decided to implement. And so this has been voted in. It's kind of a done deal, and there has been no environmental impact statement whatsoever about this. The last one they did was in Kansas, and the truck traffic went from 5,000 to 11,000 trucks per year. And so that's what we're planning to put into the Salt Lake environment. This is the airport, and then this is the wetlands, and this is Rio Tinto land that they want to sell, okay? What do we do? Well, you need to speak up. If it's a bad air day, which we have a lot of them, unusually sensitive people should be consider reducing their exposure outside. If you live in Salt Lake or in Ogden, and you have one of these days, you actually just shouldn't go outside, okay? Stay indoors on bad air days. Turn on a purifier that's equipped with a HEPA filter. Get a real HEPA filter, or a real air filter for your car. And those of us that like to save money and don't change our air filters in the cabin, that's really bad, so you should change your cabin filter. If air pollution is expected for a number of days, get out of it. Wear an N95. Those of you that have ever painted and have ever put an N95 mask on realize it's hard to breathe with an N95 mask, so you can get an idea of how serious this is. If you want to say something, you should go to Utah Physicians for a Healthy Environment, the Center for Biological Diversity, the Center for Environmental Health, the Westside Coalition, or the Salt Lake Air Protectors. Those are all things that will help your patients be healthier, but those who know, who are physicians, ought to be leading that charge. Now, the final thing I want to talk with you about is nutraceuticals. This is the nutraceutical capital of the United States, whether you know it or not. Some of our senators, major donors for many, many years was the nutraceutical industry. This is findings from the folic acid and zinc supplementation trial, or FAST trial, that we just completed recently. I'm just going to buzz through these. But what we wanted to find out was, could folic acid, 5 milligrams, that's 5 milligrams a day, and zinc, 30 milligrams per day, which are listed as important nutrients for us to stay healthy, could that improve chances of pregnancy? Because a lot of people who get fertility care use ovulation induction and insemination. And so we wanted to find out, is there something simple we could do that would actually improve the chances of being successful? Because this only has about a 7 to 12% success rate per cycle. So, boy, if you could improve that, you might avoid more people doing IVF. So let's see if we can do that. Our motivation was to see if there were potentially promising low-cost interventions that would have huge population impact. The U.S. dietary supplement industry is growing and the FDA regulation is limited, so we'd like to provide data to support their use. Supplements for male infertility are common. We'd like to know if the dosages that we've recommended are appropriate, and right now the efficacy was unproven. There's a lot of biological rationale for that. Folic is a key component of DNA in terms of purine and pyrimidine biosynthesis. Zinc is a cofactor for greater than 80 metalloenzymes involved in DNA transcription. They're also antioxidants. So this is the results. And you should be able to tell that there is no difference. It doesn't help. So all the guys that you have on vitamins, you can tell them, forget it. You don't need to do this. It doesn't help at all. What we found was, and this was almost 2,400 couples, our pregnancy rates, cumulative pregnancy rates in 3 cycles of ovulation induction with insemination, is about 35%, which is really commendable. But taking folic acid doesn't help it be any better. It doesn't help with regards to IVF. It doesn't help if you're at our fertility clinic. It doesn't help if you're at somebody else's clinic. So it is a non-starter. You don't need to do it. It does cause side effects, though. So it causes abdominal discomfort, it can cause nausea, and it can cause vomiting. And so it's not a pleasant thing to do and not necessary. So the bottom line is, folic acid and zinc is not recommended for the general infertility population. There are a lot of adverse outcomes. Doesn't improve your semen qualities, doesn't improve your birth or pregnancy rates. And I have 1 minute to answer questions.
I have several questions for you, if that's okay. I'll try to make them quick. First of all, in your workup, when you're talking about insulin resistance, do you do anything in addition to hemoglobin A1Cs? What's your evaluation for insulin resistance? My second question has to do with women who have endometriosis, and you said specifically if they've had endometriomas and they've had infertility meds, they have a higher risk of developing ovarian cancers. And I wondered if you had a recommendation for when and how to initiate screening for women as they age. Is there any agreed upon screening? I assume it would be ultrasounds, but I just wanted your opinion on that. Thank you.
Okay, the first question is about insulin resistance. So the first thing I do is look for evidence of insulin resistance in the patient. So the most common thing we see here in Utah is acanthosis nigricans. So dark spots in the creases of the skin on the back of the neck. So I look for evidence of acanthosis nigricans. And most specific Asian women who have irregular cycles have it. So you can kind of get an idea of what it looks like. I do hemoglobin A1C. I do glucose evaluations if they need to. Probably half the patients I see have diabetes when they're Pacific Islander, but the Caucasian population doesn't have that high incidence. The other thing we do is work on weight loss, so you know that if they're overweight, they have some level of insulin resistance. So I am free and easy with metformin, and if they look like they're diabetic, then I send them to one of the primary care docs to get more aggressive about their diabetes. With regards to endometriomas, we document patients who have endometriomas, and now what we do is tell them that it looks like there might be some increased risk of ovarian cancer in you, and so you do need to have appropriate screening. There is no appropriate screening that's accepted by all organizations. If you get a CA-125, it will be mildly elevated. It'll be in the 25 to 35 or 40 range, so it'll look like, well, there's a problem. But almost all patients that have endometriomas have a slightly elevated CA-125, so I'd be careful before you get that, or at least talk to the patient about it, because it's likely going to be elevated. We do a lot of ultrasound screening, and there are some gynecologic oncologists that are saying, if you have an endometrioma after you're done with having your babies, probably ought to just get your ovary taken out, or at least have the endometrioma taken out. That's very aggressive, and the true thing to do is probably somewhere between those two things. Thank you.